Start recording. So the meeting is recording. All right. Go ahead.
Oh, okay. Hello, everyone. My name's Dr. Julia Merksedal. I'm a consultant obstetric anaesthetist in the UK, in Newcastle upon Tyne, and this is the second in a series of 4 lectures on the subject of advanced obstetric anaesthesia. So, building on what we talked about yesterday, I'm going to talk about anaesthesia and analgesia for caesarean section, the state-of-the-art delivery of anaesthesia and analgesia for caesarean section. Now, the objectives of the lecture are to enable us to reduce the harm to mothers who are having caesarean section, and in turn from that, reduce maternal morbidity and mortality. The second objective is to understand the purpose of the WHO surgical briefing and checklist and its role in minimising adverse events for mother and baby, and to improve the quality of analgesia for caesarean section delivered to the mothers undergoing this operation. Caesarean section is the most common operation performed in the world, and caesarean section rates in Palestine run at up to 35%. This gives an estimated number of caesarean sections per year in Palestine of at least 40,000. Or, putting it another way, during this hour that we're engaged in this educational process, there will be 4 new Palestinians born. The maternal mortality rate for Palestine from the report from 2012 puts the rate at 21 per 100,000. Now, I'm not going to go into how these statistics are collected or whether they are entirely valid, but we'll work around on that number, 21 per 100,000. And given that the maternal mortality after caesarean section is 6 times higher than compared to a normal delivery, this means that there is a serious number of maternal deaths after caesarean section. Looking back to the maternal mortality confidential inquiry for Palestine in 2009, it stated that there was 1 death from aspiration after anaesthesia, aspiration of vomit, and of all the caesarean deaths after caesarean section, 20% of them are for pulmonary embolus. So this means that at least 8 women per year, if not 4 times that many, dies of a pulmonary embolus post-caesarean section. So keeping these figures in mind, there is one simple thing that you can all do to reduce this and improve the results after caesarean section. That is, you all need to talk more. Now, I never thought that I would be in a situation telling a group of Arabs that they need to talk more to each other, because you're well known for liking to get to the far end of everything. But as we go through this lecture, I'll develop this theme further. You need to talk to each other, which we are doing this evening on the internet. You need to talk to your nursing colleagues. You need to talk to your obstetric colleagues. You need to talk to your patients. And we'll go through how these items will add up to improving outcomes for women. So, beginning in the antenatal period, because the caesarean section does not just begin when the propofol goes in. Within the state of Palestine, 27% of women are anemic, and half of those have moderate to severe anemia. It's very important that your obstetric and midwife colleagues try and correct this as much as possible, so that the woman, when she presents for caesarean section, is in as good a state as possible before we do anything to her and she sustains blood loss. There needs to be a valid group and safe sample taken at the preoperative antenatal visit, and if the patient was at high risk of bleeding, say from an abnormal placentation or the fact that she's a grand multip or has multiple pregnancy, there needs to be blood available, and she needs to be assessed for the presence of any abnormal antibodies, which would make screening and cross-matching for blood difficult. Very importantly, every pregnant woman, certainly every pregnant woman coming for caesarean section, needs to have a risk assessment of her likelihood of developing a deep vein thrombosis during or after the procedure. And the woman needs to be given information about anaesthesia for caesarean section. So if we examine the deep vein thrombosis risk assessment, essentially, if you've only got one risk factor, that is, you're having a caesarean, you don't need any prophylaxis, but not many people have only just got one risk factor. Everybody else needs prophylaxis for deep vein thrombosis. And the Royal College of Obstetricians and Gynecologists in the UK has a set of guidelines called Greentop guidelines that are applicable throughout the whole country. And the Greentop guideline, an illustration of which I've reproduced here, says that all pregnant women should receive, with 2 or more risk factors, should receive low molecular weight heparin for a varying amount of time afterwards, depending on their risk. In my establishment, the Royal Victoria Infirmary, all pregnant women receive compression stockings in addition to low molecular weight heparin. Now, it will take some time to convince your obstetric colleagues that low molecular weight heparin is a good thing, and a greater amount of time perhaps to produce a national strategy, such as we have in Britain for the reduction of deep vein thrombosis and pulmonary embolus after caesarean section. But this is a step that you can take, that you can be instrumental in, along with your nursing colleagues before caesarean section, in applying compression stockings. It's a low-cost, easy intervention, and if you don't have the stockings, you can just use crepe bandages. So you can go to work tomorrow, do a caesarean section, and take a step that will possibly be instrumental in preventing a woman getting a deep vein thrombosis post-caesarean section. Now, this is a leaflet. Obviously, it's in Arabic, but all our patients are given it in a language suitable for them in the UK about the anaesthetic choices for caesarean section. It's downloadable from the Obstetric Anaesthetists Association. It's free to download, and I'd recommend that you provide all your patients with information on their anaesthetic choices. Now, the provision of antenatal information is not just a luxury or something that you might or might not do. The more information a woman has is being shown to reduce maternal anxiety preoperatively. And given that preoperative anxiety is a risk factor for postoperative pain, taking steps to reduce preoperative anxiety will in turn decrease postoperative pain. It also helps to promote regional anaesthesia, and this is what I mean about talking to each other. You need to start talking to your patients, and then your patients will start talking to their sisters, their friends, and telling them what a good experience they had with your anaesthesia for caesarean section. And slowly you will increase the proportion of elective sections that are done under regional anaesthesia. The target in the UK is at least 90%. I'm unsure at the moment what the proportion is in this country. Perhaps someone might be able to tell me when we have the questions at the end. So as I say, feel free to download the leaflet and start giving it to your patients. Now, the World Health Briefing and Checklist. You might be wondering, why am I talking about this in the context of anaesthesia for caesarean section? Surely she should be telling us about what you put in the spinal, how you do it, all of that thing. Now, this is as integral a part of giving anaesthesia for caesarean section as any of those things that I've just mentioned. It was introduced in 2008, and it is meant to be done at every surgical procedure in every country in the world every day. But obviously it's taking time to filter through. It's only in the past 3 years that it's been taken on board fully in the UK, but now it is a mandatory step before anaesthesia is induced. Now, the beauty of the World Health Briefing and Checklist is that it actually reduces the amount of morbidity and mortality after a surgical procedure. There are many studies that you can look up that all say the same thing, that it reduces deaths and it reduces morbidity significantly. And the results are reproducible across very low resource settings, medium resource settings, and high resource settings. So what is happening when the checklist is being done and the briefing being done is more than actually answering the questions. It's focusing the team on safety. So, pre-list. Everyone is to have a briefing, and that is the surgeon, the anaesthetist, the anaesthetic technician, the scrub nurse, the midwife, if she's involved, and everyone has to be present at the meeting. I think this picture is quite funny because you can see the 3 theatre nurses with their arms crossed like, oh God, what's all this about? You can see the anaesthetist holding forth about the checklist and the surgeons looking a bit sheepish towards the right-hand side of the picture. But every case on the list is talked through from each person's perspective. So the anaesthetist will say, we've got Mrs. Jones, she's 28, she's obese, she's allergic to penicillin, it's her first section. It may be a little bit difficult to put the spinal in, but otherwise it should be straightforward. The surgeon will say, this is the virgin abdomen, I'm anticipating no problems getting the baby out. The scrub nurse will say, everything is correct with the instruments. Now, when you first start doing it, it feels very awkward and very false and very unnecessary, but believe me, the more you do it, the more absolutely necessary you feel it becomes, and you see day to day the fact that it does actually improve safety. And one of the primary ways that it does this is it improves safe practice through better communication. So as I mentioned at the beginning, you all need to talk more. Now, this is an example of the WHO safety checklist for the UK, but you are allowed to adapt it for your situation. So this is one that I designed that you could use in your hospital, and it goes through the questions. Has there been a team briefing? Is it the right patient? Has the anaesthetic machine and drugs been checked? Is there a difficult airway? Any allergies? Have the antibiotics been given? Has there a group and safe sample taken? Is there more than 1,000 more blood loss expected? Have they got stockings on? Does the P know that they need to attend the delivery? Are the instruments correct? Now, it only takes, 30 seconds, 45 seconds, maybe 60 at the most. So why would you not take 60 seconds out of your day? Because one of the things that the surgeons will say to you is, oh, it just takes too much time, and I've got to do my ward round from yesterday, and I'm just going to come when the patient's ready or the patient's asleep. You have to insist and be firm. And gradually the culture will change, and they will understand that it's actually in their interests to attend safety briefing. At the end of the operation, you have a second checklist to sign. Are the instruments correct? What was the blood loss? If there was a specimen, has it been correctly labelled? Has there been post-op analgesia written up? And has there been a plan for post-operative DVT prophylaxis? Again, another 30, 60 seconds out of your busy day that can do a lot to promote patient safety. Now, talking about the question, has your equipment been checked? And again, once again, you might feel that the lecture's being a little advertised wrongly because this is about anaesthesia and analgesia for caesarean section. However, I'll go on to illustrate how this is very important. In the UK, every anaesthetic machine and the equipment must be checked every day before the start of the list. There is a logbook that the anaesthetist has to sign to say that they've checked it, and this is kept on the anaesthetic machine. And again, you might think, well, you know, on the whole, the machine's okay. What a waste of time that is. However, you wouldn't ever get on a plane if you had that sort of attitude coming from your pilot. It is your responsibility to check and know that the equipment you're about to use on a patient is in working order. So I will tell you a cautionary tale. I was called in the last 2 months by a trainee to assist in a difficult intubation in a caesarean section. The laryngoscopy had been abandoned because they were unable to view the larynx. There was an attempt to ventilate the patient with 100% oxygen with a face mask, and then the anaesthetic machine failed. So, moving to plan B, the ambu bag was dug out of the bottom drawer of the anaesthetic machine, and it had perished and was no longer self-inflating. I thought at that point in time I was going to have to do mouth-to-mouth resuscitation of the patient, because she was going hypoxic at this point in time. That is the sort of situation that should never arise in a hospital. And if you know that your equipment is in full working order at the beginning of each day, you will not get into a situation like this with your patient, which is all about giving excellent care for caesarean anaesthesia. Now, just aside for a moment, talking about failed intubation in obstetric anaesthesia. Again, in Britain, we're a small country and we have a unified health system, so it is a lot easier to implement countrywide protocols. So this is the failed intubation protocol for general anaesthesia from the Difficult Airway Society and jointly with the AAGBI and the OAA in Britain. You will see that it says stop attempting laryngoscopy after 2 attempts. Now this is very counterintuitive because you feel that you need to keep trying, and if you just have another go you will be able to get the tube in. But if we think back to last night and we look at the decreased FRC, the alteration in the oxygen hemoglobin curve and the hematocrit and the oxygen carrying capacity, your patient will start desaturating. And it's very important to not get task fixated on intubating your patient when it's difficult and you need to abandon and oxygenate your patient and decide what to do next. So finally, we get on to how to do a spinal anaesthetic for caesarean section. Now, the role of us in this in the caesarean section is to provide anaesthesia for the section, avoid hypotension, reduce visceral discomfort when the uterus is exteriorized and when they are suturing, provide post-operative pain relief. So if we look at all of those in turn, we will see what is best practice for each of those things. So analgesia for caesarean section begins antenatally by giving the woman information. It's been shown that they have less pain if they have the presence of a supportive birth partner with them, and in the UK the patients do get to bring their husbands into the operating theatre. Quite clearly that's not an option here at the moment, but in the absence of a supportive birthing partner and the absence of a midwife present in the operating theatre until the time of the birth of the baby, You're the one who must be supportive towards the mother. So you need, going back to saying that you've got to talk to people more, you need to talk to the woman. You do this every day of the week. She does this, well, at most once every year or so, but probably once a lifetime or twice a lifetime. She will be scared. You are in a position to reassure her. On a pharmacological level, if you give spinal morphine, you will provide analgesia for 24 hours post-operatively, and you will be able to attenuate the visceral sensations that are felt by the patients from handling of peritoneal covered structures. The dose ranges from 100 to 300 micrograms, so the trade-off is between better analgesia versus more side effects, in particular pruritus and nausea. So perhaps opt for the mid-range dose, that being 150. You'll have to see what works in practice for you. On a note of caution, there are two issues here. Your morphine must be preservative-free, and also you must be very, very careful to maintain asepsis when you're drawing up your morphine, because you're going to have to draw it out of a 10 milligram ampule and dilute it up to 1 ml and then take out 0.1 or 0.15 of a ml. It's very important to maintain asepsis and to be clear on your the dose that you're putting in, microgram dose and not bigger doses spinally. Now, we talked yesterday about epidural top-up and the pharmacokinetics of PKA, lidocaine versus bupivacaine, and the adjuvants, bicarbonate and adrenaline. The answer to the epidural top-up analgesia question is 3 milligrams of morphine. Again, it's like the spinal dose. You can range from 1 milligram up to 3 milligrams. You just have to pitch it to, like I say, pain relief versus pruritus and nausea. Skin to skin bonding of the baby, so placing the baby on the mother's chest after birth is actually a good analgesic in itself. It certainly distracts the woman from the points in the operation where they're suturing the peritoneal covered structures, and it's been shown to promote breastfeeding as well. Again, it's a difficult to change culture. The midwife gets the baby, she wants to weigh it, label it, process it, and get on to the next job. But slowly you can change your culture within your theatre and get it so at least the baby meets mother before it exits the operating room. So, again, it's the sort of $64 million question. What did you put in with what dose? Well, starting off with your endpoint, you need a block to T4 to cover the visceral and parietal peritoneum. The spinal dose that you use to achieve this depends on a number of factors. The speed of your surgeon, which here is very quick, compared to the surgeons in the UK who are very slow and seem to spill a lot more blood than your surgeons. Depends on the size of the patient. You're not going to put the same dose in a woman who's 2 meters tall as you are in a woman who is 1 meter 40. Depends on the position of the patient, whether they're lying or sitting, and it depends on the barbotage and the speed of injection. So, a starting dose will be 2.2 ml of heavy bupivacaine. We end up having to put a lot more in because, like I say, the surgeons are a lot slower. You just, again, have to find what works in your setup. Anaesthesia for cesarean with epidural top-up. The success of the epidural top-up depends very much on how the epidural is performed in labour. If you have been asked back more than once to adjust the epidural to try and achieve analgesia during labour, you're unlikely to be able to top it up adequately for cesarean section. As we talked about, your choices are lidocaine, bupivacaine, plus the addition of fentanyl, and the adjuvants are bicarb and adrenaline. If your epidural is not performing or your top-up is inadequate, you have two options. You may just go straight for GA, or you may wish to put a spinal anaesthetic in. I just advise a note of caution putting spinals in after epidural top-ups, because you are more likely to get a high block and in some cases a total spinal. But it's a difficult call because you need to put enough in but not too much, and there's no right answer to that question. So you might be better just going straight for a general anaesthetic at that point. Post-operatively, as I mentioned, you're going to give between 1.5 milligrams and 3 milligrams epidurally. Now, very importantly, important to the mother and important to the fetus, what are our strategies to avoid hypotension in cesarean sections? We talked in detail yesterday about the anatomical mechanics and the respiratory changes, which are obviated by left lateral tilt and perhaps a 45-degree head-up angle. The tilt will avoid your aortocaval compression as much as possible without turning your patient entirely laterally. You're going to augment that with the use of vasopressor, and we need to talk about the use of oxytocin. So, in 2002, there was a definitive study done by Cooper et al. On the fetal and maternal effects of phenylephrine and ephedrine. The bottom line is phenylephrine is better, less hypotension, better fetal pHs. There have been many meta-analyses since. However, if you try phenylephrine using the correct regime, I can guarantee that you will not go back to using ephedrine. So much so that when you counsel your patients preoperatively about side effects intra-op, it's hard to remember to tell them that they might be sick once you start using phenylephrine. Such is it an improvement on the use of ephedrine. The other advantage of using phenylephrine is there is no need to preload. The mechanism of action of preloading was to try and make up for the splanchnic vasodilatation that you get with the sympathectomy from the spinal. The phenylephrine, being an alpha agonist, actually causes splanchnic vasoconstriction and so directly deals with this problem. If you titrate it carefully, the dose, to minimize hypotension, the hypotension almost becomes negligible and certainly not perceived by the patient. And better cord gases in healthy term neonates, and more importantly for those neonates that are in peril with a abnormally functioning placenta, you are going to achieve better fetal outcomes with the phenylephrine. However, it's not quite the wonder drug. You have to use it very strictly, and if you don't use it strictly, you will get into the same trouble that you used to get into with ephedrine of roller coaster blood pressure, tachycardia, and vomiting. Most importantly, you need to have a working flushed cannula. It's no good having a cannula that's been put in, it's been sitting there for half an hour. Your assistant attaches the phenylephrine to it, you put the spinal in, you turn it on, nothing happens, and then you get on the roller coaster of hypotension. It needs to be working and flushed, and you need to check that before you wash your hands to put your spinal in. The phenylephrine needs to be started as soon as has been completed. How you give your phenylephrine will depend on your resources available locally. We give it via a pump, so we put 10 milligrams and 100 mils of saline It's 100 mics per mil, and we give 30 mils an hour. And essentially, you double it and halve it, depending on how the blood pressure is going. It's just as effective to give it via an infusion set, so 10 milligrams in 500 mils of saline, which is 2 mics per mil. Give 4 mils a minute to start with, and titrate to effect, looking at the blood pressure. If you give too much phenylephrine, you will get a reflex bradycardia, but it seems to have quite a fast onset and offset, so you've got quite a margin for if you take your eye off your giving set, because obviously a safer setup to be giving it via an infusion pump. But if you don't have an infusion pump to hand, that's fine, you can still use it just as effectively. You just need to label your infusion correctly and keep an eye on it throughout the section. Now, the next strategy for keeping the blood pressure up in your patient is we need to re-examine the role of oxytocin. Now, we all know that ergometrin is a dirty, nasty drug that makes your patients vomit. It gives them pulmonary hypertension. It's really a nasty drug. And carbaprost is not entirely without its side effects either. We tend to look on oxytocin as being the benign neurotonic. However, we have been lulled into a false sense of security. And so if we just look at oxytocin in a little more detail, it causes myometrial smooth muscle vasoconstriction. This is mediated through the G protein mechanism, and essentially it increases the intra muscle fiber calcium, therefore getting a greater contraction. However, its effect is not just confined to the uterine smooth muscle. It's a potent arterial vasodilator, has a direct negative inotropic effect on the heart, and it causes coronary artery vasoconstriction. So, your baby is born, you give the oxytocin, and the blood pressure drops. Your patient starts complaining of chest pain. You say to the patient, oh, it's just what they're touching inside of you, it's just because they're reaching up under your ribs. No, actually, they are actually having coronary artery vasospasm. If you look for ST depression after giving a bolus of oxytocin, you will find it. And certainly if you have an older patient who's a smoker, possibly diabetes, overweight, you can often see ST depression on the ECG after the bolus of oxytocin. So it is not the benign drug that it appears to have been. Also, there's a chap in Stanford called Alex Butwick who actually went back and did the dose finding study for oxytocin, proper lab ED90 study, and the ED90 of oxytocin in the setting of caesarean section is less than 3 units. Now currently in the UK we give 5 units as a bolus. It's meant to be given as a slow bolus, but most people just put it in, and then the patients receive an oxytocin infusion should they need one, if they have risk factors for uterine atony. Again, I'll refer you back to the RCOG Greentop guidelines. They're available on the internet. Even with this dose, you can get quite alarming hypotension and chest pain. And if your patient has a fixed cardiac output, you need to reduce the dose to less than a unit over 5-10 minutes. So if I just illustrate that, this was a case I was called to. When I arrived, the woman was in frank pulmonary edema, but prior to my arrival she'd been a little bit hypertensive. That had settled down, the trainee had given the 5 units of oxytocin stat, and the next thing that she'd written on the anaesthetic chart was very difficult to get blood pressure assessed clinically. Well, I think if she'd been assessing the blood pressure clinically, she might have had a little trouble finding the pulse, because the next automatic blood pressure reading was a systolic of 58. Now, this patient turned out to have she was in a routine elective section. She'd been seen in the morning. She was relatively thin. She'd been saying, "I've been a bit short of breath," and everyone had just said, "Well, you're term pregnant, madam. You know, pregnant women get short of breath when they're term." However, she had a very bad undiagnosed peripartum cardiomyopathy, which was unmasked in quite a spectacular fashion by the oxytocin bolus. So if I could just emphasize that it's not a benign drug, you need to go back and look at the doses that you're giving, and there is a ceiling effect. Once you give the 3 units, giving more will not cause the uterus to contract more. This is going to be a difficult battle with the obstetricians that you're going to have, because they believe in it. They even use it in evacuations of retained products of conception, although there are no oxytocin receptors in the uterus less than 12 weeks. And the reason it stops ERPC's bleeding is it drops the blood pressure, not because it's contracting the uterus. But I'll stop now, because obviously I could expand further on the evils of oxytocin. It's a good drug, it stops people dying of postpartum hemorrhage, but we need to be giving it in the correct dose. So let's move on to analgesia for the women who have general anaesthesia, either electively or as an emergency. So after the birth of the baby, you need to give the woman an opioid, because you're going to have given her hypertensive response to the laryngoscopy, and you've also inflicted a massive amount of pain on the woman over the preceding sort of 5-7 minutes that it's taken them to get the baby out. So again, the choice of opioid is what you have available in your unit, or what you give as standard. We give morphine 10, but fentanyl 200 is equally as acceptable. Like I say, whatever you've got, use that. You must always give an antiemetic whenever you give an opioid. And then, once the surgery is finished, go on to use a transversus abdominis plane block. Now, the use of tap blocks, if people have had intrathecal morphine, doesn't say in a spinal, doesn't help. However, in the situation of a general anaesthetic where they have no intrathecal opioid on board, the transverse abdominis plane block is absolutely excellent for pain relief. So you give it to improve pain relief, reduce morphine consumption if they're using a PCA post-operatively, and you can use ultrasound or a landmark technique. And again, this is a very satisfying block, because you don't need an ultrasound and loads of fiddling about to locate it. If you're used to doing an epidural, it's a very easy loss of resistance TwoClicks technique. So if we look, here's the left lateral flank of a patient. You can see that they've drawn on the subcostal, quite a short patient by the look of it. Anyway, so drawn on the subcostal margin, the iliac crest, and you can see he's got an ultrasound probe, but where the arrow is, if you put your finger, you're going to be able to feel the triangle of Petite, which is where the 2 aponeuroses cross over, and there's it's the inferior lumbar triangle. So if you go through the inferior lumbar triangle with a blunt needle, you'll find 2 clicks as it goes through the aponeuroses of external oblique and internal oblique. You're then in the transverse abdominis plane. And if you deliver 10 mils of bupivacaine and 10 mils of lidocaine into that space bilaterally, it actually although it seems high for a fan and steel incision, if you think the uterus and that part of the abdominal wall is innervated by the lumbar plexus, you're actually going to get better spread to the lumbar plexus as it spreads posteriorly towards the nerve roots. So, post-operative analgesia. I think there's a lot of women having cesareans in the world who don't get post-operative analgesia. However, our society is not at that place anymore. We need to give pain relief for cesarean section because it's humane. Nobody should suffer pain. Pain of childbirth is one thing, but the pain of having an abdominal operation is not something to be put up with. If you relieve pain, you'll have better breastfeeding, less postnatal depression, earlier mobilization, with a knock-on effect to DVT. And you need to give, in addition to the manoeuvres that you've done intraoperatively, whether that's your intrathecal morphine or your opioid plus tap blocks, is you need to give a regular paracetamol and non-steroidal for at least 2 days afterwards. So, if I can summarise what I have gone over, the safe conduct and successful conduct of caesarean section anaesthesia begins in the antenatal period. Caesarean section is a leading cause of certainly morbidity and definitely mortality. And using the World Health Organization team briefing and checklist system will enable you and your team to reduce adverse incidents, morbidity, and moving on from that mortality by improving the safety culture of your organization. You need to tilt your patient. If you're giving a spinal, you need to use an intrathecal opioid with phenylephrine for the best effects. Little hypotension, minimal hypotension, maximum analgesia. If you're giving your patient a GA, you need to give them an opioid plus a tap block, and you need to give them regular paracetamol and non-steroidal. And this will give you good results. For your patients who satisfied, pain-free, mobile, happy patients who are able to look after their babies. And you have facilitated this by your good practice. Thank you.
Questions?
Hello?
Yes.
Hello?
Hello?
Yes, please.
Hi, thank you. Thank you very much for this lecture first. I want to ask about sedation. If you have a patient in cesarean with spinal and it was not enough. So what do you prefer to give sedation after, if you give sedation for these pregnant women in the cesarean?
I think often, once you've put the spinal in, you may be pressurised by the surgeons to start. Before the block is up at T4. So the first thing to do is to check the height of your block using a cold technique, which is simple, so just using some cotton wool and some alcohol. If your block does not reach T4, you have the option of doing it again. But if you start and the patient's complaining, either of pain or she's interpreting the visceral sensations as pain and discomfort, the easiest option is to put on some nitrous oxide and oxygen, and then once your baby is born, you can move on to, say, some midazolam, some IV opioid to supplement the spinal anesthesia. But the most common reason for the pain is not waiting long enough for your block to come up to T4.
Do you have experience with ketamine IV in small doses, just to?
I have used remifentanil. We have remifentanil available in Britain, and it's a very short-acting, fast onset, fast offset, powerful opioid that's metabolized by plasma choloesterases. It's absolutely fantastic for tiding people over where the anaesthesia is slightly inadequate. I don't personally have any experience with ketamine, but I'd be nervous about giving ketamine without giving benzodiazepine.
Yeah, because of the hallucination, yeah. Another question, please. If you give morphine for the postoperative pain in the spinal, do you keep the patient or the pregnant woman more time in the recovery to make sure that she will not have respiratory depression or something like that?
No, no, because if you're going to get respiratory depression, it would be later rather than in the initial post-operative period. However, the respiratory depression that you get from 150 mites of morphine is the same that you would get if you were giving your patient an equivalent dose of an oral opioid for the pain. So I think, you know, the risk is probably more feared than realistic, although, you know, there'll always going to be cases where someone gets respiratory depression, but your patient should be being monitored when they're back on the ward anyway, to some degree.
Another question about the marcaine, the bupivacaine. Do you use isobaric or hyperbaric bupivacaine in the cesarean?
Hyperbaric, because the isobaric is unpredictable, and you're more likely to get a high spread but with a patchy lumbar block.
Yeah, that's my problem here in Al-Makassar, because they are using isobaric, not hyperbaric, and we are trying to have the dextrose 10% without preservative to mix it. And what is the dose do you use in the spinal, in the cesarean section of hyperbaric bupivacaine?
Well, 2.2 to 2.7 mils of 0.5 heavy hyperbaric.
That's more than 10 milligram? More than, yeah?
It is, yeah, 10.2 or 10.4. Like I say, it depends on how quick your surgeons are. Ours take absolutely ages, so we put 2.7 mLs in, which sounds like a really enormous dose.
So you put the hyperbaric bupivacaine, morphine, and fentanyl, or just morphine?
Well, if you put fentanyl in, that gives you better visceral sensation control intraoperatively, but I think it just starts complicating things a bit too far when you've got all those different ampules and everything. So I think, you know, if you're going to put an opioid in, just stick to one and stick to morphine, because you don't get post-op analgesia with fentanyl.
Do you have experience with the methadone in the epidural?
I don't, because in Britain we use diamorphine as our standard opioid, but if you read the American literature, they are big fans of slow-release morphine, but personally I've not used it myself.
I don't have experience with morphine in the epidural, just in the spinal, because we used to use methadone more in the post-operative. In the epidural, I mean, not in the spinal. What other questions I wanted to ask? Okay, thank you for now. If I remember something else, I'll...
If you think of anything else, just get in touch with me. I'd be more than happy to correspond over any cases or matters that you have.
Thank you very much. I have difficulty now to convince them about the synthesinone, the pitocin, the oxytocin. Because they insist to give more higher doses than the 5 units.
They won't know. They won't know if you just put the 5 mils in. You can always give some more. You can't take it out.
Yeah. So yeah. Okay. Thank you very much. Thank you.
Julia, can I throw something in
Okay.
the discussion? And that is when you mentioned the dose of hyperbaric bupivacaine, the oh boy, this is tell you what, I'll disconnect my let me disconnect. Can you hear me okay?
Yes, that's fine. Yeah.
Good. All right. When you mentioned the dose of hyperbaric bupivacaine to Rawand, to Dr. Rawand Ratrout, and what something I have noticed, and that is an old tradition in medicine that's been going on for a long time. I noticed that when I first started working in Palestine is that everyone gave 10 milligrams of hyperbaric bupivacaine. Well, unless the woman is very short, 10 milligrams is usually not enough for the majority of women who are more than 1 meter 50, that's 5 feet tall. And most women are taller than that. And I asked them why. They said, oh, no. We're not allowed to give more than 10 milligrams. That's 2 cc's of 0.5% hyperbaric bupivacaine. And I said, that's just not enough. And they said, well, that's because 2 years ago we had a case of severe hypotension. And since then, they told us we can't use more than 10 milligrams. Well, that's why, yeah. Yeah, that's why you went to medical school. That's why.
The issue there is that in order to have an adequate block for cesarean section, you must have a block up to T4 where the sympathetic fibers enter. So you will have to have a sympathectomy to have an adequate block for spinal for cesarean section. Therefore, it's not to give an inadequate dose of bupivacaine, it's to give an adequate dose of your vasopressor and to use the other maneuvers to prevent the hypotension.
Correct. And that's what I want the residents to hear is that and now when I am supervising them doing a cesarean section, and I tell them in America I use 15 milligrams for everyone who is taller than 1.60 m and shorter than 1.90 m. And I have a lot of tall women in America. But the reality is you can't just have one dose to fit all patients. I think that's the message that a lot of the young people have to understand, that that's why you are a doctor. That's why you titrate the dose.
Yeah. I mean, there are many. We could have a whole lecture. We could spend a whole hour talking about the factors that govern height of block, duration of action, speed of onset, speed of offset. So what I've tried to do is just give you the middle ground, which is 2.2 to 2.7 mils. So 12.5 to 17.5 milligrams.
Can I say something?
Of course.
Yes. About the hyperbaric bupivacaine, where I worked before in Hadassah, we used to prepare it not to have it in milliliters, not in 5 milligram per cc. We used to prepare it. We used to take bupivacaine 3 cc, which is 15 milligram, and to add 2 cc of dextrose 10%. It will be 3 milligram of hyperbaric bupivacaine per cc in 5 cc syringe. And we used to give only 9 milligram of this hyperbaric, which is 3 cc to the cesarean, or even less sometimes if the pregnant woman is short. Some of them even gave 7 milligrams, which was enough for the cesarean section with fentanyl or with morphine. So now in Al-Maqasid, because I have only isobaric, I I have difficulty to assist the dose of the cesarean section. But just to say that we used to give less than 10 milligram even for the cesarean section of hyperbaric puberty.
I think if you're using ISO, what you need to do is you need to use a slightly bigger dose. You're going to have a bigger volume, but you need to have your patient head up. So keep them head up so that you can get it to fix in the lumbosacral area before you flatten them out.
You mean in the isobaric to keep
Yeah,
them
if you're using isobaric, put it in and then don't lie them flat straight away so that you don't get the spread upwards, that you can try and fix it a little more caudally.
Yeah. But we used to give the 9 milligram or 8 milligram of the hyperbaric and keep her sitting for 3 minutes or something like that. 3 minutes, yeah. And after that, we asked her to lay down. But in the isobaric, you mentioned that I have to keep her a little bit in the antitrandylan bed.
Yeah. I think the thing is, you have to use what you've got, and you have to adapt it to your patient population. What I've described here is just what is ideal in my environment with my set of patients, and I'm totally respectful that you have to find what works with you. But I think the point that Hafez made about the hypotension is, in order to have an adequate block for cesarean section, you have to have a symplectomy because you have to have got up to T4. So it's all about the vasopressor and the positioning to prevent the hypotension.
Okay. About the vasopressors, you mentioned that phenylephrine is better than the ephedrine. You don't use at all ephedrine in the spinal incision?
We haven't used it for about 5 years in the UK.
And the dose is phenylephrine. You keep her on infusion pump with phenylephrine, or just policies?
No, infusion's better. You can either do it by pump or just do it the old-fashioned way and put it in the bag, as long as the bag's correctly labeled.
For all of them, or just if you suspect that she will have hypotension?
Everyone.
Oh, good.
The neosynephrine dose in boluses, and in the United States we use it in boluses mostly.
Yeah, we also in Israel, in Hadassah, we used to use it in boluses, not in drip.
120 micrograms. The famous study that Dr. Morshidal mentioned, 120 micrograms boluses was associated with no side effects, no significant hypertension or anything. The only so it's and it preserves uterine blood flow far better than ephedrine. The only time I will use ephedrine, and I have 2 drugs drawn up for a cesarean section. If the patient is hypotensive, still hypotensive despite 120 microgram bolus of neosynephrine, if I give her 120 micrograms of neosynephrine, and she's still hypotensive, her blood pressure systolic is maybe 85 or 90, but now her heart rate is 50 or 55, I will give her ephedrine, usually 10 milligrams. If her blood pressure is good, 120 or something like that, but her heart rate is so slow that it's 35 or 40, and I have seen that, then I give small boluses of glycopyrrolate, which of course is not available in Palestine, but you can substitute that with atropine.
Yeah.
I prefer glycopyrrolate. Glycopyrrolate is the same price as atropine. I don't even know why they don't buy it, but at any rate, that's the.
Well, I think what it is, doctor, the lady doctor, is that if you try the phenylephrine via infusion, you will honestly not bother going back to ephedrine or doing boluses. It just really transforms it into a beautiful, smooth operation, as opposed to one where you're handing the vomit bowl to the patient and it's all just really horrible.
Agree. I agree.
I didn't understand that point.
Oh,
If
you
Well,
can,
she says that the continuous infusion of Neosyn
Phenylephrine, yeah.
is very smooth.
Okay. I don't have experience with this, but I can try it in infusion, because either I give boluses of 50 mic or even 100 mic, or as she said, to put it in the drip of 500 cc saline, 10 milligram with the.
if you talk to Dr. Mustafa Qureshi or Dr. Ayman Marar, they've had experience of the technique and they'll be able to tell you a little more about it, perhaps more convincingly than myself, because they've seen it here in Palestine.
But you need another infusion for the. If you need to put another, or you put just with the stop cook with the.
Yeah,
you need, because I noticed that in the cesarean you need one for the fluids, one for the synthesinone, for the oxytocin, and another one for phenylephrine, or just to put it
if you use the phenylephrine, you don't need to fluid load.
Yeah.
So unless there's bleeding, you don't need a second cannula. You can just use a three-way tap.
As a career, yeah, with the fluids. Okay, I'll try it. Good. Thank you.
Thank you.
T4, Hamamde, Majdi Hamamde has a question about T4 if it's not too high. I say no, but what do you think, Dr. Morshidal?
What's the question, sorry?
The question from Hamamda is T4 too high a block?
No, because the sensation that is supplied to the peritoneum is T4 in origin. So you're cutting through the peritoneum. It has to, unless you're not anesthetizing the peritoneum unless you get up to T4.
Do you understand that, Majdi? Fahim? You are not anesthetizing the peritoneum until you get up to T4. Do you understand that, or do you have another question? I don't think he has sound, so he can't participate viva voce, but Majdi, please ask your question to the public on the green chat, not on the... yes, you understand that. Okay, he says he understands that. Unfortunately, he's been... Some surgeons ask for methogen.
Right.
What do you think?
Okay.
Another question from
Methogen is what we call ergometrin. Okay, so if there's a, like the WHO pain ladder, there's a ladder of uterotonic usage. So you start with oxytocin, you move on to oxytocin infusion, and then as a second line treatment you will use ergometrin, methogen. You must only give it IM. You must never give it IV, and you must only give it in a maximum dose of 250 micrograms. So otherwise the side effects are just too bad.
There's another question, Majdi Hamamdi. Can you change your chat to all instead of just me, from private to all, so Dr. Morshidal can see this, because the discussion here is very important. Okay, Dr. Hamamde has a question about vomiting with neosynephrine, specifically with neosynephrine. I've never heard of that. Have you ever heard of that, Dr.?
The vomiting is secondary to hypotension, not to the neosynephrine.
I'm sorry, can you come close to the microphone?
I said the vomiting will secondary to the hypotension, not to the phenylephrine.
That's right. No, phenylephrine, as far, in my experience anyway, does not cause vomiting by itself. The problem with vomiting, the reason you get nausea and vomiting from hypotension during labor, during anything else, is ischemia to the chemoreceptor trigger zone in the brainstem, and which is caused by hypotension. So any hypotension caused by anything, by any etiology, will cause nausea and vomiting because you have ischemia to the chemoreceptor trigger zone. Uh, but you've never heard, Julia, of any
No,
vomiting,
it's
nausea, just
secondary to the hypotension. And also perhaps not having the peritoneum anaesthetized.
Julia, do you see on the side here, in the chat box, from also Dr. Hamam, he says sometimes they get vertigo with opioids in the spinal.
No, no. Maybe if you're using isobaric, but not if you're using hyperbaric.
I have an answer for this question. Most of Dr. Morsidal's patients, most of my patients, are used to a little bit of vertigo because they will go to the bar and have a beer or two or three. And the vertigo, a slight amount of vertigo is actually desirable because they feel a little bit good about the vertigo. زي ما انت بتأرجل هيك، يعني لما بتبلش تأرجل، بيحصل لك vertigo شوي. Ladies in general, well, in the Middle East, alcohol consumption is not common, is very rare, and so forth. And so vertigo is a very new experience to them. This is something that I've noticed ever since my early training in Egypt. So yes, you have to tell them that it's okay. You have to reassure them. You have to communicate with them. You have to tell them to close their eyes. It's okay to have a little bit of vertigo. It's better than pain. And just go from there. Yeah.
Good.
Julia, I have, there are a couple of things there are a couple of questions that I have.
Okay.
When we started doing tab blocks, transversus abdominis plane block in Palestine a couple of years ago, the surgeons, of course, were complaining because what does a surgeon do? He does two things: he cuts and he complains. And they were complaining that their patients were weak. That's because they got a little bit of a fascia iliaca block, because it's the same block, you're just a few inches above and a couple inches above, and so they will get some femoral nerve, lumbar plexus block, and they will be weak. And do you have this problem in Britain? And outside of putting a knee immobilizer on the patient, which we do in America, but what else? Can you tell our young colleagues in Palestine?
Well, I think you're always going to have a risk of motor block when you're blocking a sensory nerve if it's a mixed nerve. You could perhaps alter the dose and the volume to minimize your motor block. So, for example, in the UK, you could use ropivacaine, which has less motor block. But I think what you have to do is weigh up the risks and the benefits of the whole proceedings. And the overall thing should be that a big push towards as many regional anesthetics as possible for your patients. Then the fewer, you should have like 95% of elective sections being done under regional. That should be what you're aiming for. And at least 70% of your emergency cesarean sections under regional. Now, obviously, that's not going to happen overnight, but in the meantime, it is only humane to provide good analgesia. Now, if they end up with a bit of a femoral block, you know, for 24 hours, they'll cope. They will, as long as they don't fall over. But I mean, there's lots of women have obstetric palsies after labour anyway,
Right.
with femoral nerve palsies and optional.
Majdi has a question about carboprost.
Yeah. Okay.
Carboprost.
Yeah, carboprost is the third line uterotonic. It's a fridge item, so it's important that it's kept refrigerated. 250 micrograms, you give it IM, and you can give it at 15-minute intervals, and it's the third line drug for atonic BPH. It's contraindicated in asthmatics. It will provoke severe bronchospasm if you give it to an asthmatic. And it's very important that you only give it intramuscularly and never intravenously.
Okay. Other questions, young people? Okay, I have a question for you, Julia, and for that question, I will have to take over. I will have to take over for just a moment, okay? So I can show you my screen and show you an abstract from a study on 700 plus patients that we did in Rwanda some years ago. All right. Okay. You have been made the presenter. Please close confidential windows and click show my when ready. Show my screen. Okay. Hold on. Okay. Now you can see my screen. Now I will show you an abstract that we presented in was it South Africa or Buenos Aires? I forget. But at any rate, this is an abstract that we presented. Paulin Rohato and these long names are Twagiro Mugabe. Twagiro Mugabe, you know, Twagiro Mugabe in Rwandan just means Abdullah. فاسمه Theogen Abdullah. At any rate, this is the abstract, and we had a grand total of 602. I'm sorry, not 702, 602 consecutive parturients, cesarean sections at a hospital in Rwanda. I'm sorry. In with 23% cesarean section rate, and they were 1 in 5 were urgent and semi-urgent and so forth. But the rate of general anesthesia, which was very, very poorly defined, usually general anesthesia in Rwanda for a cesarean section just means ketamine and Valium and diazepam. All right, 13 parturients. The mortality of parturients in peri-C-section mortality was 0.5%, which is 500 per 100,000. Okay, that is 2,500 times the mortality from cesarean sections in Western countries. Let me repeat. For every Canadian woman who dies from a cesarean section, and I'm comparing this to Canada, 2,499 died in Rwanda, and this yet has to be established statistically. I'm trying to harass them into doing a study, but that's because most C-sections in Rwanda are done by general practitioners, not by obstetricians, because Rwanda has only a nation of 10 million people. They have only about 25 obstetricians, if that, probably about more like 20. So can you, Julia, go back to the C-section mortality, and I'll make you the presenter again in a second here. Can you go back and tell us the C-section mortality in Palestine? Okay, I think it's your second or third slide, or third or fourth, something like that.
Yeah, I'll go back. Yeah. Right. Well, before we look specifically at the cesarean mortality in Palestine, what I would like to say is that the absolute fundamental thing with obstetrics and obstetric anesthesia is that we do not need new knowledge in order to reduce maternal mortality. We don't need new drugs, we don't need new operations, we don't need to discover any new knowledge. All we need to do is implement what we already know and do that better within the resource environment that we have. The figures that you've shown from Rwanda, from Rwanda, the maternal mortality of women is very much reflected in the woman's social status within the country and also the stability of the country itself. So the fact that they've had a massive war is going to make maternal mortality go up. Now, if you have the resources, if you're in a medium resource environment, you can bring maternal mortality down. Okay? And what I want people to realise is that you're going to work, you can reduce the risk of a woman dying. But that does not begin when you pick the propofol syringe up or when you pick the spinal needle up. You have to rewind, and the process of safe anaesthesia begins in the antenatal period. The patients in Rwanda, they won't have antenatal care, they won't have access to the hospital, they'll be presenting an obstructed labour. This is not what you're dealing with here. You're dealing with an equivalent to a Western setup. You just need to pay attention to the small details on a national level, and you will make a further impact into maternal mortality. Although it is acknowledged that after what's happened in Gaza, that the maternal mortality in Palestine will go up as a reflection of the disruption that there's been there recently.
Right. What is the C-section? Didn't you have a C-section mortality figure for Palestine?
Well, I had to estimate a minimal. The mortality from cesarean section is 6 times higher than normal birth. Okay. Now that's not the only direct anaesthesia death was aspiration, but the deaths post cesarean are mainly from pulmonary embolus and secondary to the obstetric problems such as a hemorrhage or eclampsia. But I felt that the two things that we could make an impact on would, as anaesthetists, are the aspiration and the PE rate.
Now keep this. Can you keep this slide on for a second?
Yeah.
Because maybe you're politically you don't want to be talking about things like that, but I'm an Arab. I'm from a country next door, immediately next door, and they're telling us that Egypt has a maternal mortality rate something similar to this. 21, 25, 60, 70 per 100,000, which I find ridiculous. Because the World Health Organization says that Egypt has a maternal mortality of about 800 per 100,000. That's
Yeah.
0.8%.
Yeah.
That's close to 1 in 100.
Yeah.
Now, I don't know where the truth is, but 21 per 100,000, America has about 3 or 4 or 5 per 100,000. And for that to be in Palestine, for that to be only 21 per 100,000, I think these are, unfortunately, and I hate to say this, it's a terrible thing, but I think these are government statistics, and you can't
Well,
trust them.
there's two ways. The best way is to triangulate. The best way of collecting the maternal mortality rate is to triangulate from the statistics that are offered up, and then to do nested control studies where you interview women and ask them how many people they know that have died in labour. So if you put those two things together, you will get a more representative figure. It was 45 per 100,000 in 2009. So it's always just a guide rather than a specific figure.
Yeah. You don't have to feel too embarrassed, you guys, Shabab. Dr. Julia grew up in Kuwait, so she's part of the team. She's with us. You don't have to be embarrassed, but yes. But the shocking thing, I think, the pulmonary embolism, because in most low-income countries, maternal mortality comes from, I'm sure you know, bleeding, hemorrhage.
It doesn't in this country. It doesn't. Only 20% of your deaths are direct maternal mortalities, in contrast to a low-income country where it's going to be 80% of the deaths. What you're getting the influence from is that the biggest cause of death in women of childbearing age is actually MI followed by breast cancer. So you have a nation of smokers who are getting increasingly overweight and not doing much exercise. So that's going to implement
inbreeding
on your mortality. So what you really need, well, it's not for me to say, but you need a national strategy for the prevention of PE, because it's completely, you can do it, and it does make an impact, because we've been through this in the past 10 years in Britain. We've got our PE figures right down.
Yeah, and I think consanguinity causes, even if people are not related, they are related, because it's a very small nation. 5 million people total in Gaza, the West Bank, everywhere. 5 million people. So even if you are not related officially, you're related. You're still part of the same gene pool, genetic pool, and diabetes, hypertension, coronary artery disease, cerebrovascular disease. I think it's a big problem.
Yeah.
Any further questions, young people? There's Oh, Ramon is here. Hola, Ramon. ¿Cómo estás?
Hola, ¿qué tal? Muy bien. Can you hear me?
Yeah, I can hear you.
Can you hear me?
Yeah.
Yes, I can hear you fine. We can hear you fine.
Sorry, but I can speak very well English, so I am silence. Sorry.
That's all right. Ramon is from Spain, and he's been a wonderful contributor of a lot of information on the website, on the Facebook page, and the Facebook page has just been a wealth of information. There's a young man named Muhammad Amir from Nablus, whom I'm sure you met, Julia, but he's very enthusiastic, quiet kind of guy, but enthusiastic. So, any further questions? Can we end the meeting?
Okay, thank you very much, everyone, for your attention.
Thank you all. Let me go back to me being the organizer so I can stop the recording without so I